Welcome, everybody. Thank you for being here for the Law Medicine Conference. We're really pleased to be able to put this on. I had heard this before, but it just struck me again today that the Law Medicine Center has been around since 1953. So if you can imagine, that is by far the oldest center in the country. We're really proud of the work that it does. And Professors Melman and Hoffman, their leadership, have, of course, put on lots of great programs over the years, and including this one today. I will turn things over to Professor Melman. As many of you know, he is a distinguished university professor, which is the highest academic award a professor can achieve at the university. And of course, he also co-directs the Law Medicine Center. Professor Melman.
Thank you, Dean Rose. So I want to begin by thanking all of the people who helped to put this program together. Our speakers volunteering their time. A number of them were hoping to be here in person and had last minute problems, family problems and things like that. So they will be here with us remotely, giving their presentations later today and tomorrow. I also want to thank the planning committee, a number of professors and practitioners and excellent help putting this all together, some of whom you will hear from and others will be just having helped us. I also want to thank Patty Harbold, who is outside doing, who is the director of our programs, and she is outside helping to do registration and so forth. I also want to thank our audiovisual assistants, Rob Combs, who's in the back, and others who've helped us put this together. For those of you who are participating remotely, you can ask questions. We will have time for questions after each of the presentations, and you can ask your questions on Q&A, type them in, and we have someone who will be monitoring the website and will speak your questions to us and to the speakers, okay? For CLE credit, there will be, you can get CLE information, which will be placed in the chat at the end of the day, and there's a activity code which you will get at the end of the day as well. Unfortunately, we were unable to get CME credit due to some last minute complications. The only thing we can say is that we will be happy to refund the registration fees for any physicians who are counting on CME credit. That's a joke because there were no, but sorry about that. I'm going to introduce the program. When I was a kid, I was prone to ear infections. And more than once, a doctor would come to our apartment in the middle of the night to lance my infected ears. And later, when we had penicillin shots, give me a painful penicillin shot. Think about that. Doctors came to my, a doctor came to my apartment in the middle of the night, no questions asked, to treat me, right? When I was in high school, I attended a small boarding school in the early 1960s near the small town of Stockbridge, Massachusetts, in Western Massachusetts. And if a student became ill, the teacher drove them to see Doc Campbell. This is Doc Campbell. This is Doc Campbell, who had his office in Stockbridge. And it was in his house in Stockbridge. Dr. Campbell saw us almost immediately, right away. He smiled, warmly and reassuringly, and gave us thorough examinations and decided how we should be treated. And then he treated us by himself. Since in those days, according to the American Academy of Family Practice, small town doctors like Doc Campbell did all kinds of things. They did, for example, they treated every kind of disease and injury, infectious diseases. They set broken bones. They delivered babies. They even provided end-of-life care. Think about your experiences today in attempting to get access to care. Think of primary care. Here's a description of what some patients typically experience. Let me read this to you. So you feel sick, you try to make an appointment with your primary care physician, and you're told that the soonest you can be seen is in 3 weeks, but that you can go to urgent care or call 911 if this is a life-threatening emergency. You're not sure if your condition is life-threatening, and you want to see your physician rather than a stranger in an urgent care clinic or be taken to the emergency room in an ambulance, so you wait. Finally, the day of your appointment arrives. After showing the receptionist your insurance cards, filling out forms, and sitting in the waiting room for an hour, a person who is not your doctor collects you and takes you to an examination room. They don't tell you who they are. They ask you questions, then say that your doctor will see you shortly. Eventually, the physician comes in and sits down in front of a computer across the room with their back to you. They type as they speak. 5 minutes later, they tell you either that you need to see a specialist or that they'll phone a prescription into your local pharmacy. Then they get up and leave. But that doesn't mean you get the medicine. It's not like when Doc Campbell gave me a written prescription and I could walk across the street to the Rexall drugstore and get it filled right away. Your insurance, for example, may not cover the prescribed drug, in which case you either don't get it or you have to pay for it yourself, or even worse, you may not have medical insurance. And even if your insurer covers the drug, you may have to pay some of the cost yourself. In 2019, people with private health insurance provided under Medicare's so-called Part C, Medicare Advantage plans, paid an average of over $4,000 a year for extremely expensive drugs, such as the one that treats hepatitis C. Or the insurer will make you first try cheaper alternatives before paying for the one that your doctor prescribed. And you may have changed insurers, and the new one requires you to stop taking the expensive one and start trying the substitutes. In some cases, this can be life-threatening. When an ulcerative colitis patient was required to spend 6 months trying several substitutes before being able to take the physician's recommended treatment, his health deteriorated to such an extent that he had to have his colon removed. So the question is, why is healthcare today so different from the way it was 50 or 70 years ago? What happened? What changed? Well, in order to answer that, we have to go back in time, and we have to really go back to the beginning of the 19th century, the early 1800s. There were some people in those days who called themselves physicians. Typically, they were at universities. They had practices for the aristocracy or the elite. But for most people, care was given by herbalists, apothecaries, barber surgeons, folk healers, and so forth. So they were basically highly skilled tradespeople, okay? Highly skilled tradespeople. And there were some sort of unusual approaches to medicine in those days. So this is Samuel Hahnemann. He was the progenitor and proponent of a field of medicine called homeopathy. Homeopaths believed that the way to treat illness was to give the patient something and the smallest dose of something that would create a condition similar to the condition that they had, but less serious. So if you had a patient with a high fever, you would give them something that would produce a low fever. And the homeopathic idea was that the body would be distracted from the high fever and focus its attention on the low fever, and the patient would no longer have the high fever. Homeopathy. Very, very popular. The Hahnemann Medical Center is still, I think, in operation in Philadelphia. I think it was recently sold. The first private hospital in Cleveland was a homeopathic hospital. Did you know that? The first private hospital. It was Huron Road Hospital. That was the first hospital. It was homeopathic. So that was one school of thought. There was another one. Some practitioners followed Samuel Thompson. Samuel Thompson believed that all things that were wrong with you were caused by imbalances in air, fire, earth, and water. And the Fifth Element, in case you didn't see the movie. And anyone could be a physician. Anybody could call themselves a doctor if they followed his beliefs and paid him a $25 franchise fee. The Thompsonians. And even the so-called orthodox practitioners had some dubious ideas. So this is Benjamin Rush. Benjamin Rush was a renowned physician. He was a signer of the Declaration of Independence. He had 3 primary treatments: bleeding, purging, and blistering. Bleeding, what does that do? It weakens the patient. Purging, they used a calomel of mercury, which was poisonous. And blistering, that's just painful, right? And this was the premier physician in those days. So in 1847, 250 physicians, all men, I'm sorry to say, held a meeting at the Natural History Museum in Philadelphia, and they vowed to transform the practice of medicine. They vowed to make it from a skilled trade into a profession. Well, what makes a practice a profession? So what do you need in order to be a professional? According to sociologists, study the professions, there are three hallmarks. The first is that you have to limit those who can be in the profession. It's not going to be open to anybody. It's not going to be open to anybody who pays Samuel Thompson's $25 franchise fee. And at the turn, when the republic began after after the Revolutionary War, and in the early years of the country, there were licensure laws. The colonies and then the states had licensure laws. You had to have a license in order to call yourself an actual physician. But those licensure laws were repealed during the administration of Andrew Jackson, who did not believe in regulating things, something we maybe hear again, and also with the help of the followers of Samuel Thompson. So the Thompsonians and the Jacksonians rallied together and convinced the state legislatures to repeal the requirement that you have a license. So one of the things that the physicians who got together in Philadelphia in 1847 vowed to do was to restore the requirement that you have a license in order to be able to practice medicine. The second requirement for a profession is that you have specialized knowledge and skills that can only be acquired through a rigorous training program. Okay, so you had to go to, and that was not required in the early part of the 19th century. But again, the physicians who met in Philadelphia vowed that this would now be a requirement. In order to have a license, you now had to graduate from an accredited medical school. And that medical school had to be accredited by a council, by a group which they formed called the American Medical Association. They formed that at that meeting. And in order to be an accredited medical school, the school had to teach scientific medicine and the emerging germ theory of medicine. You couldn't teach any of the fringe theories that were there at the time. And that was what you needed in order to be licensed. So that's the second requirement. The third requirement for being a professional or being a profession is to place the interests of others above your own self-interest. And the doctors who met in Philadelphia adopted the first modern code of medical ethics. And there was a key statement right at the beginning. Here's the key statement right at the beginning. Physicians should minister to the sick with due impressions of the importance of their office, reflecting that the ease, the health, and the lives of those committed to their charge depend on their skill, their attention, and here's the clincher, fidelity. Fidelity. And this ethical principle was reflected in the AMA's code of ethics that followed through the years. The current code, Principle 8, says that a physician shall, while caring for a patient, regard responsibility to the patient as paramount. The third requirement for being a profession. So it took the AMA and its supporters the rest of the 19th century to accomplish all of this, to get all of the states to reinstall licensure requirements, to accredit medical schools. They did the Flexner Report in the early 1900s. That was not entirely salubrious results. They shut down a lot of black medical schools at the time, which was unfortunate. But by the end of the 19th century, beginning of the 20th century, they had accomplished basically these three goals. And physicians, in the early part of the 20th century, basically regarded the health of their communities as their responsibility. And, small town doctors like Doc Campbell, if you couldn't pay, well, leave a pig or leave a sack of potatoes. And if you couldn't do that, well, okay, you'll pay me next time. That was kind of the philosophy. And they weren't particularly, extremely wealthy, but they had enormous social status. They were leaders of their communities, and they were venerated by their patients. And here are some other pictures of Norman Rockwell of the doctors that that sort of symbolize this relationship with Doc Campbell in the middle. Okay. So what happened? Well, This began to change in the mid-1960s. What happened in the mid-1960s was an enormous influx of government money, federal money, due to the adoption of Medicare and Medicaid. A wonderful program building on the Social Security programs of President Roosevelt, but they had the sort of unintended result that they got enormous amounts of capital, enormous amounts of money into the healthcare system, really for the first time. And there's a story of Lyndon Johnson, who was president at the time. His aides were so concerned about how much the Medicare and Medicaid was going to cost the federal government that they came to him and they said, this is too much money. What should we do? And Johnson thought for a minute and he said, well, I guess I should call my brother. And they sort of looked puzzled at him, didn't know what that meant. And he explained that there was a fellow who was being trained to be a railroad switchman and had to take an exam. And at the end, and one of the questions in the exam was, there's a train coming down the track at 60 miles an hour, and there's another train coming in the opposite direction on the same track at 40 miles an hour. What do you do? And the fellow thought for a minute. He said, well, I guess I'll call my brother. And the examiner said, why would you do that? And he said, because he's never seen a train wreck. So that was Johnson's response to the enormous amount of money that was being infused into the healthcare system, really for the first time. And what it did was it opened the doors to basically the takeover of the medicine, the delivery of healthcare by big business. And instead of physicians, in control of what their patients received and the care that they were given, increasingly business people became in charge of how to run healthcare providers and facilities and so on, MBAs. And you can look at these, anesthesia building consultants, improve your practice productivity with us and so forth. And I'm sure you're all familiar with these kinds of business consultings. And healthcare, as you know, became very, very profitable. Very profitable. So this was the net profit margin in 2016 of the 10 most profitable industries in the country. And you see pharma as the most profitable and interestingly, generic pharma as the most profitable, which really is kind of interesting. A brand name, a pioneer manufacturers, so-called, are the fourth most profitable. And then you can see going down, right? And I'm just picking on the drug companies, but the most profitable drug companies at the time were, you can see the kind of profits they were making, 50%, 60% profits. We also saw enormous consolidation in the healthcare industry, if you will. In 1990, these were independent hospitals in Cleveland. They were all independent hospitals, okay? Are they still independent hospitals? This is what we have now. No offense to Metro, right? And we'll hear more about this later, but corporations and private equity began to buy hospitals and physician practices. As I'm sure you're all aware, about 80% of physicians are now employed by these businesses. They no longer have independent practices. In 2023, 36% of hospitals receiving reimbursement from Medicare were for-profit hospitals, 36%. One such a company that owns hospitals, you may have heard of this one, HCA Healthcare, right? You've heard of HCA, right? Owns 184 hospitals, 184 hospitals. To put that in perspective, the entire Veterans Administration only operates 172 hospitals throughout the country. And even supposedly not-for-profit hospitals make a lot of money. They just can't call it profit. In short, the delivery of healthcare, risks being transformed from a profession into a business. And unfortunately, making money for these businesses, meant placing constraints on physicians when they wanted to do what they thought was appropriate for their patients, spend more time with them, have better staffing for them, have better equipment for them, prescribe the proper medications and treatments for them. So what was happening, largely because of the way we paid for healthcare, was that the costs of healthcare were skyrocketing. And in the early 1980s, the amount of money being spent on healthcare was growing so fast and was so great that health policy people, led by a fellow named Alain Enthoven, said, we have to bring this under control. We have to start curbing spending better than we're doing. And what they came up with was the idea of managed care. We have to manage care. Basically, we have to second guess doctors when they want to do something for their patients and not just let them do whatever they like because it's too expensive. Now, insurers, health insurers had always, would get a bill after, a claim from the doctor after they treated the patient. And they would, they wouldn't just pay it willy-nilly. They would review it and decide whether it was appropriate to pay it. But the key was that was after the patient got the care. Okay, the patient got the care. Okay, in the mid-1980s, to facilitate this idea of managed care, the health insurers began to switch to reviewing whether or not to pay for something before the patient got care. The practice that you're familiar with known as prior authorization. Okay, and you'll hear more about that later. And physicians, now are being second guessed. They're being employed, and we'll hear more about the problems that employment creates. But the bottom line is that, again, the risk is the loss of being a professional, and going back to the way it was, before the profession was really put together in the mid-1800s. A prime example of what can happen is this is a testimony by one physician to the Federal Trade Commission in 2024. I'm sorry, I thought I had a slide. Emergency physicians are expected to average 3, 4, and sometimes more patients per hour during their shifts. For any of you who have taken a loved one to the emergency department, consider that the physician your loved one is being cared for is under pressure to spend 15 to 20 minutes or less to see, order tests, review tests, make a plan, and complete a chart for them. Then consider that during this shift, some very sick patients require upwards of an hour of bedside care in order to save their life. Tremendous pressure, tremendous pressure. So this threat to professional status has significant costs. Significant costs. Obviously, there are costs for patients. One of the costs is the loss of trust. Remember how revered, how trusting patients were of their physicians back, in the earlier parts of the 20th century and so forth. A 2014 study ranked the United States 24th out of 29 industrialized countries in the proportion of adults who agreed that doctors in their country could be trusted. 24th out of 29. And when patients lose trust, there are financial and emotional costs on them, right? Instead of using money to pay for the care they need, they have to get a second. They're determined to get a second and even third opinion, and so forth. And of course, if the patient is seriously ill, afraid, in pain, think of the emotional toll that not being sure that you can trust your doctor because of the pressures that they're under. And if patients can no longer trust their physicians, that imposes serious costs on the physicians. A 2022 survey by the American Medical Association reported that 62.8% of American physicians experienced symptoms of burnout. I'm sure you're all familiar with that. Other studies found that 1 out of 5 physicians intended to stop practicing within 2 years. A 2018 survey of US physicians, which was the last one before COVID, found that 62% are pessimistic about the future of medicine, 55% describe their morale as somewhat or very negative, 49% would not recommend medicine as a career for their children. And this has, of course, a practical consequence for physicians because we know that patients are much more likely to actually bring a malpractice suit if they have less trust in their physician than if they trust their physician, even under the same circumstances with the same mistakes. They're willing to adopt the view of the National Academy of Medicine that to err is human if they trust the physician. So this has that burden for physicians as well. So the theme of this conference is to spend this afternoon exploring more of the problems that physicians face. And we're going to hear some personal stories from some physicians and then invite anyone in the audience to share additional stories with us. And then we will hear about the sources of these problems, the problems created by being an employed physician, by private equity ownership of practices, and corporate takeovers and so forth. And then tomorrow, starting in the morning, we will hear about some of the efforts to fix these problems, and we'll look at the law. The laws that have been passed, and how they've been fulfilled or not. And the goal of tomorrow is to think about what can we do to strengthen protections for physicians when they try to do the right thing for their patients. How can we make sure that they can continue to be professionals in the full sense of the word, and that their patients get the proper care that they need? Okay. Any questions about what I've talked about? Comments or questions? Anybody offline? No? Okay, well, we're ahead of schedule, which is, I think, good. But what I'd like to do then is to invite, our physicians. We have several who have volunteered to give us the benefit of their experiences. And if they would come up, our first speaker is Deanna Berry, who is a pediatrician from Bath, Ohio, and Jess Levy. You can come up here if you want. Yeah, we need a microphone. And then we have also Jesse Cox, who is an emergency physician from Tillamook, Oregon, who will be with us virtually. And I hope, since we're ahead of schedule, that she will still be with us. Okay. So you can sit back here if you like, or stand at the podium. Sure.
Just want to go ahead and start?
Yeah, and introduce yourself, please.
Hi guys, I'm Jess Levy. I'm a child psychiatrist and adult psychiatrist. I am currently proud owner of a boutique practice called A+ Psychiatry. I do general psychiatry, but it's mostly specialized in ADHD across the lifespan. And tomorrow when I speak, I'm going to get more into like how that came about, as precisely because of some of the things we're talking about today and how that came about. So funny you say that about the 48% of parents. You said 49% of parents don't want their kids to be doctors. Because I'm one of those. So I very clearly, so my mom was a psychiatrist, and I clearly remember this was I was going to undergrad, so it's the late 90s, perfect timing for this. And she's like, "Don't go to psychiatry, don't go to medicine, Jess. Just don't go to medicine. It's a bad idea. Don't go into medicine." So when she graduated medical school in the late 70s, I guess they called it the golden age of medicine or whatever for doctors. I mean, she was like all the prestige and the good pay and all that stuff like that. And she tells stories about like pharma sponsoring like her. She didn't have to buy a stethoscope ever. Stuff like that. It's crazy. And she's like, if you become a doctor, what's going to happen is this productivity. You can't take a vacation. If you take a vacation, your productivity is going to go down, and then you're not going to get paid. So you got to work. And also, if you do the wrong thing, you're going to get sued by some lawyer who's going to quote the Journal of Medical Obscurity. I remember she talked about this. I was wondering if there's a Journal of Medical Obscurity that's going to be used against me at a court of law. So like, I don't know. It's just very much like be afraid. And I don't know. I still into medicine anyways. I flipped at a lot of things. So a couple of things, you actually already mentioned a lot of this about managed care, productivity, administrative burdens. She just saw how it's eroded her joy in like medicine and stuff like that. And she had a very defensive, pessimistic view. I think that was instilled on me about what physicians, and that's why I say therapist. But anyways, so just my journey is this. I was really into academia. I went to, first I went to Wright State for medical school, and then I went to residency, and then I went to fellowship at UH, and then Cleveland Clinic for my first gig. And I thought academics was going to be perfect. It's going to be the trifecta. With my ADHD, it's like, this is perfect. You get the research, you get teaching, you get clinic care, all of that. It's going to be great. And in theory, it was great. The problem is my personality, especially with everything going on, just did not go well with a large corporation type thing. That productivity thing, it was not the way my mom explained it, but it was still did just feel this onerous thing, this feeling that I got to do more and that I got to justify my schedule and just more and more and more and justify my schedule. Like if I wanted time off, just a vent. If I couldn't do it. Like we had to have reasons for why we wanted to take time off, and it had to, be financially sound. And then I just give this an example. This is sort of thing that would go on when I was on call. Okay, so I lead a call. We manage the pediatric and patient behavioral health unit, and at the time, the admission records. So when you go through the admission set, and this is when you're on call at home or whatever on your computer, there's a question that says patient received flu shot or patient declined flu shot. Now, these are pediatric patients. It's the middle of the night. They've been admitted for suicidal ideation. They are not allowed to consent for anything. And we're not going to track down the parents at 2 a.m. Oh, by the way, your suicidal kid, do they get a flu shot right now? Like, it's just not going to happen. But the way it worked, and this is like about the eroding the trust thing, is the way it worked is when you document, it didn't give you any other options because that's just the fast, efficient way to do it, right? Productivity, I assume somebody's made a template. So I'm like, well, no, it didn't get a flu shot, but I don't want to say that the patient declined or the family declined because they were even asked, but I can't say yes, they got a flu shot. And so now I'm like all worried about it. I think about the journal of obscurity, getting sued and all that. And I think about like, what's it look like if the patient's a discharge summary and let's say they don't already trust me to begin with. And then it says, oh, and by the way, they declined a flu shot. And granted, this is just one tiny thing. I mean, this is not like, I'm talking about a freaking flu shot. Like, that's really what we're talking about here. But like that caused so much consternation, and I'd go back through and manually edit the discharge summary later, but like, well, the patient was not did not have the opportunity to receive a flu shot or something like that, because like whatever. Anyways, so I did that. I broke up with Cleveland Clinic. Now, okay, let me back up. There are people who do great in academic medicine, who flourish, who love it. And I don't want to be like the man. It's again, It's like, I mean, it's just for me and the way I practice that I like to go slow, I like to be thorough, and I do like to build relationships with patients and dig deeper. And I like ADHD and we ramble, and I like to ramble with my patients when they ramble. It's not good profit margin for any major employer. I get that. So then I kind of broke up with them during the pandemic because actually what it was is we were working from home, and I was like, I was like praying that the pandemic would continue because like, please, I don't want to go back to work because I don't have any panic attacks going to work. I mean, the flu shot thing was a cause of consternation. I mean, patients calling like on my lunch break, they're suicidal, and I'm like, I can't get you in. Like, don't die. Please. Like, I'm gonna go see you at my next lunch break. All right. So then I went to a small community mental health center, and it was very different. It was the breakup. I mean, they gave me complete control of my schedule. I didn't have to rationalize anything. There was a productivity requirement in name, but not really. I mean, no one's really stressed about it. However, I was equally or even like unhappy there for different reasons. Even though that need for to do that justified productivity wasn't there. With community mental health, a lot of it, they're really good and innovative at being a safety net for the community. Their charges, I think about like follow the money, right? They're getting paid to do a job to help the community as a safety net. I, as a physician, wanted to more work on things like innovation. How do we practice better care and things like that? And again, that's not to say that this is I'm right or they're wrong or whatever. It was just again a mismatch that led to some burnout. For example, one of the things there I remember, again, it was that they had this own, because, it was highly bureaucratized. Anytime a patient had a suicide attempt, we had to fill out an incident report. And they would actually and if the incident report got rejected, we had to go back and refill it. And I said to them at one point, I think this might be discouraging clinicians from asking about suicide. Because, like, if they can fill out an incident report, patients, oh, yeah, I did have an attempt last week. That's an incident report, right? And I was like, and by the way, I mean, you think about I get it, we're trying to avoid this and not trying to be callous about it, but we don't have like family doctors fill out incident reports every time a patient has a stroke, things like that. Like, not that we want patients, but like, it's an unfortunate thing. And I think the message we're sending by this is that it's this terrible thing, and it's making. And the answer I got was, well, no one's complaining. That's the way it's done. Which, yeah, I mean, I was the only one complaining. I was the squeaky wheel, and I get that. So eventually, I did start my own private practice after that, A+ Psychiatry. Where I'm at with that right now is I do like a flat rate thing, like a membership thing, kind of a hybrid, and I can geek out about that. It is better. It's based on my values. I think just for me personally, And I very much, one thing I've learned along the way too is I very much lean into my ADHD. And we were talking about patient trust and stuff like that, and just being my authentic self. So I tell patients, like, look, I got ADHD. If I say I'm going to say do something and I don't, please nag me. If you're nagging, and I tell patients, like, and we were talking this even beforehand, like, what are you doing with setting limits with that? And so just I can be myself. The truth is, and we'll talk about this. Anytime you're making money off of sick people, there's got to be some ethical dilemma, right? I mean, that's what it goes. We're making money, and we're dealing with sick people. And yes, I do. Okay, so right now I don't take insurance, and that does burn me up. I didn't want to be a psychiatrist to the stars, and I get a lot of guilt. But then again, I can't be everything to everybody, and I do try to maybe help out by doing teaching, having students with me, doing conferences and stuff like that. So hopefully it works out. But yeah, I guess that's kind of my story. There's no perfect system. But it's just I think it's just a mission that finding that right fit or the best fit.
Hi, so I'm Deanna Barry. I have a bunch of notes, but I'm just going to kind of tell my story. So I'm from Northeast Ohio originally. I went away to Florida for 15 years. I did my undergrad at University of Florida. I stayed down there for medical school and for residency. Loved Florida, but missed family. So when my husband and I had our first born, we decided to move back to Northeast Ohio. So I joined a hospital system, not the little one on the screen, one of the big monster ones. And I loved it at first. I honestly felt when I joined there that I was going to retire from there. I was part of a small practice that was employed by the big hospital. So I had the backing of the big hospital, but I felt like I could still practice medicine how I was hoping to. Well, as I moved further along, I was building my practice and I started to have less time because when you first start, you don't have any patients. And so you got all this time. And then as your panel fills, they start to require you to see more patients in a smaller time frame. So I wasn't able to move fast enough for their liking. So right before the pandemic, actually it was right at the time of the pandemic, I had a baby in the July. So the pandemic, March 2020, I had a baby in July, and I gave my notice over my my maternity leave because I had received a second pay cut for my productivity. And I, at that point, was going to either leave medicine or do something completely different. I had I love what you described with the definitions of profession because when you go into medicine, especially in peds, I'm a pediatrician. I don't know if I mentioned that. We do not go into it for the money, okay? But we have to make a living, and we pay a lot of money to get through medical school, as I'm sure some of you, I don't know, who here's law school, who's med school? Med school? Okay, great. Law school? Okay. So you know what it's like. You're taking on a lot of risk, right? And you're increasing your debt. So ultimately, I met with my old pediatrician who did not make house calls, but was still the guy that I had my whole life. And I took him out to lunch, and he later tells me he thought I was going to offer to buy him out when I left. He thought I was moving home to take over his practice. And I said, I'm so sorry. No, but I am thinking about going in on my own. And he said, don't do it. He said, I'm retiring. I'm trying to sell my practice. It's too hard. Reimbursements are lower and lower, et cetera, for all the reasons we know. So that was discouraging. I left that meeting and I thought, well, I've got to think outside the box. I have to do something different because if I was to go to one other hospital system, it will be more of the same. And again, there's nothing wrong with the hospital system I was at. It's just that medicine is a business. It's a corporation and they're in it to make money. And that's usually at the expense of your patient's health. So I decided to open my own practice, and one of the things that I think was the biggest blessing in disguise was that I had a non-compete in my contract from when I joined. And when I joined, I had already been in practice for a couple years in Florida, but I came in and I was just excited that this hospital wanted me. I did not question the contract. I did have a lawyer review it, but I did not stick up for myself or advocate or make any changes. And now in hindsight, I realize it was a blessing, but I had a non-compete that I wasn't able to practice within a certain number of miles for a certain number of years from where I was practicing. Well, the caveat to that was that it didn't say you couldn't build practice. It said you couldn't join another competing hospital system. So that was my out. So I decided to open my own practice. 1 mile away from my previous practice. And it's direct primary care. Have any of you heard of direct primary care? It's a newish concept because it actually is very old school, old fashioned medicine. I do house calls. I go see my patients. They come to my house. I'm very close with my families. It's a similar concept to Dr. Levy in that it's a membership. And so families pay me monthly or an annual premium. And through that, I'm able to give them appropriate, good, sound medical care. I feel good about, I'm fulfilled. I feel good about the type of practice that I have. My patients know me well, they trust me, and it's a beautiful option for some. There may be like one of you that end up doing it, and that's okay, but just remember this exists, because when I was going through my training, like this is such a gift to you, that Case is explaining the different options. I had never even heard of DPC until I was already in the process of knowing I was opening my own practice. And then I was like, wow, there's this other option. And it changed everything for me. I have about a tenth the number of patients that I used to have. So it's a small panel, but I see kids and I have an hour-long checkup. I don't have to go through growth, development, hearing and vision, vaccine, anticipatory guidance, all the things that I did in a 15-minute checkup for my little kids at my old practice. That wasn't good for them. It wasn't good for the parents. They left with questions unanswered. I didn't feel good about it. I was staying up late, staying at the office late, upsetting my family because I was finishing the clicks of the notes and following up with my patients because it was the right thing to do. You don't get time to make the phone calls and follow up and be that type of doctor you want to be. But I know why you get into medicine is to be that type of physician. So I'm just really, really thankful that there is another way. For those, I technically I'm full time, but I feel really called to letting people know this is an option. I don't care if I'm like one tiny little blip on a map. I don't need to grow. I'm not planning on having other physicians join me. I'm happy by myself. I don't want to grow, but I really want to grow the movement. It's a really powerful, it's the antidote to the train wreck that we are. I really think this is going to be where ultimately it's find their purpose and their calling again. And I really do feel like it's better medicine for the patients. I do have a pharmacy. I know you mentioned about the medicine. I keep a pharmacy in a house for my family. So when they come in and they have strep, I have amoxicillin right here. Don't bother using your insurance. I get it at wholesale price, so I give it to you super cheap. And families never want to go to the pharmacy because it's one less stop if they're sick kid. So it's a one-stop shop. I do procedures. It's all included in their membership fee. Whether you use me once this month or you come see me every week this month, it doesn't cost you an extra penny. So yeah, that's kind of the type of practice I have. I'm happy to talk to you a little bit more. I did not go over anything that I actually planned to talk about, but I just gave you my story, and I'm happy to tell you guys a little bit more about direct primary care if anyone has any questions.
And we'll hear more about that tomorrow, actually. Tomorrow morning, we'll be talking about that, one of the solutions to this problem and see how to think about it. Okay. So I would like to turn to Dr. Cox, who is with us virtually from Oregon. And please tell us your story, your stories. Enlighten us as to the troubles that you have seen.
Yeah, so Jesse Cox actually grew up in Northeast Cleveland as well. Moved out here to Oregon to go to Reed College and then went to med school out here. Did emergency residency at University of Iowa, and then I went straight from residency to my dream job, which is a unicorn emergency medicine practice that I highly recommend anyone considering emergency medicine find. So our practice is owned by 4 emergency medicine boarded physicians. We have 100% emergency boarded physicians working for us. We cover 1 emergency department in Tillamook. It's single coverage, rural critical access. So we're an hour and a half in a full mountain pass away from basically any specialty. It's terrifying. It's hard. It's fulfilling, and I love it. We work for ourselves. We decide everything from, are we going to hire more? Are we going to hire less? Are we going to work more? Are we going to work less? To giving feedback to each other, to doing reviews, to all of that stuff. I was thinking about in the last couple days what I would want to know if I were sitting where you guys are, still back in med school. And I think the biggest thing I've learned since leaving training is the business of medicine, which I'm hoping they're teaching you guys more than they taught us. Obviously, this conference is way more than I even had when I was in your chair. Um, so for those of you who don't know, I'm sure some of this will get covered and got covered, but the way we are paid as physicians, at least from my perspective, is there's this thing called an RVU. It's the way I explain it to people is a patient comes in the emergency department. It's not only that patient, but it's how sick they are and how much effort and energy they need. And so I write my chart, and my chart gets sent to a coder, and the coder determines how many RVUs it is. And then that goes to billing, and billing goes to insurance, and then we get paid for it. So the other thing to know is that pediatricians and other primary care people, their RVUs, they get less RVUs for the work they do. They get paid less for their RVUs. Um, Whereas you have proceduralists who are doing surgeries, who are doing things, which unfortunately tend to be because something went wrong. You're sick, you have an injury, you have whatever, which could be prevented. Um, those specialists and those RVUs, those work units, are paid higher, and there's more of them for procedures. So an hour isn't an hour in medicine. It's an RVU is what it boils down to. Um, my personal company, we have had this amazing contract with the hospital where we're actually paid per RVU for all of our patients that we're seeing, and then they do the billing. And they do the coding and they do all of that stuff. So my personal story on this was 2018. Our contract was up for renewal, and 6 months prior, the hospital decided that they were going to change to in-house coders. So they took a bunch of people who were coders and they trained them on emergency medicine coding for, I'm going to guess, but say 10 hours. And they said, okay, you can do this. Now, we had an outside company that we were paying, the hospital was paying to do this. Our RVUs per patient overnight dropped by 33%. Pretty sure that our patient population didn't change overnight by 33%. So in our contract negotiation, we said, hey, excellent attempt. I'm glad you tried to bring this in-house. Great. We're never doing this again. And so our negotiation with the hospital, and it's now in our contract, is that we will agree on a coder, because that ends up how much we're paid. And, you know, unfortunately, a lot of medicine comes down to payments. I have to be able to pay my doctors. I have to be able to pay malpractice. I have to be able to pay our lawyer. I have to be able to pay our accountant. And if I can't do that, I can't show up to work. So that was just my one small episode of where our hospital got to decide how they were going to code, and we had to go to a contract to make sure that it happened the way that we needed it to. I don't have tons of personal stories, fortunately, because like I said, we're our own group. We contract with one hospital. Our president actually used to be a paramedic, so he's fabulous and loves emergency medicine and understands. He lives there, his family lives there. We get to care for his family. He gets to see us. And so it's kind of the closest to old school medicine that Professor Melman was telling you guys about at the beginning that I can get. But I do want to tell you a big story that's happening in Portland, which is that Providence, so imagine Godzilla of the big hospital systems out here in Portland rather than Cleveland, for the first time ever had a strike that included physicians. It's currently going on. 5,000 nurses and physicians from 7 different hospitals have gone on strike. Today is day 44, if I'm correct, because they were no longer willing to accept the level of staffing that they had on the floor. So they didn't have enough nurses, they didn't have enough CNAs, they didn't have enough of what they needed to provide safe care. From the physician standpoint, because that's what we're all here for, the labor and delivery doctors were paid for one physician to be there 24 hours a day. So 2 12-hour shifts is how it worked. if one of the physicians felt that they were overwhelmed and they had too much acuity or too many patients, they had to call in one of their colleagues, but that colleague wasn't getting paid. So they basically were volunteering their time to come in to cover each other, which they did because out of the goodness of our hearts, the best thing for the patients, but they're not getting paid. And oh, by the way, the nurses aren't getting head counts based on how sick the patients are. They're just getting head counts based on exactly how many numbers of patients you have. So you can have the sickest of the sick. It doesn't matter. That counts as the same as an ankle sprain. I'm exaggerating, but you get the point. So the hospital system, for the first time in my knowledge, rather than spending their 10 days notice before the strike started trying to negotiate, they spent that time trying to fill in the staff. Able to do it for nurses. They've done it all over the place. There's nurses, lots of places. You pay enough money, a nurse will come. In the last 3 days before this strike, they realized that they couldn't replace the physicians. And so they asked the physician negotiating team to come back to the table to negotiate in those 3 days. And the physician said, nope, not without our nurses. We're not here for us. We're here for our nurses. We're here for our patients. And so fast forward to now 43 days later, they're still out on the picketing line. There's a couple of the contracts that have been figured out, but all of this came down to the point that the physicians were no longer willing to do this out of the goodness of their hearts because it's affecting patient care. And so I'm hoping that this is a one-time thing, and I'm hoping that conferences like these help us all to realize that we do have a voice. We just have to use it, and we have to be willing to walk out of the hospital or talk to people or open our own practices or whatever.
Thank you very much, Dr. Cox. We will hear more about unions tomorrow morning. I'd like to invite any physicians in the audience to share with us any stories that they might have about the problems that they encountered in trying to do what they thought was appropriate for their patients. Anybody want to join us? We have a microphone if you'd like. Lily? Well, you can come up here, or we can just bring a microphone to your. Yeah, anybody.
So I have like a prior authorization story. And I'm a part of the Academy of Medicine of Cleveland. So we'll be talking with them. We're going down to the State House next Wednesday. So we'll be talking more with them about this. So a local family doc. I had a patient who joined my practice last fall. A few months, we got her up to date on, health maintenance. She was due for a mammogram, so we ordered the mammogram. She was a small business owner, so she finally got insurance. That was hard for her to get, but she was able to get it. So we got the mammogram so she could afford it now that she had insurance and it was covered. And then after she got it, it showed that it was positive for a finding on one of her breasts. So could be cancer. The radiologist recommended an MRI. So another physician who's trained to read scans recommended an MRI. And the insurance wanted a prior authorization first. So they were like, nope, we think this needs more information. So I, as the family doctor, had to go back and forth with the insurance. Took about a month to finally talk with somebody and get the approval to get this MRI for her. And they didn't have a reason for prolonging this process. They didn't have a reason for waiting. They just wanted it to go through these hoops to make sure that it was truly recommended. So I was a little blunt with the person on the phone. I let them know that another physician recommended it. I was ordering it as the family doc from the recommendation of the radiologist, and they eventually approved it. And she had breast cancer, so her diagnosis was delayed by at least a month by this prior authorization process, and not to mention the anxiety of the patient having to wait a month to find out if she had cancer or not.
I'm Gary Battati. I'd like to thank my cousin, Dr. Robert Battati, and Mr. Melman for inviting me here today. I practice urology in Youngstown. That's disease and surgery of the kidney, bladder, prostate gland, and the genitourinary system. And I was fortunate. I didn't have a lot of the issues that you're talking about today. I did have some, and I retired about 22 years ago, so things have changed radically even since then. But I remember one case where I was called by the emergency room physician about 2 o'clock in the morning, and he felt that he had an 8-year-old boy in the emergency room there that had a torsion of the testicle, and that's where the testicle actually just twists on itself due to impaired ligaments there that never attached properly. And if this is not addressed rather quickly, the testicle can infarct. In other words, the blood supply would not be there, the testicle would atrophy and no longer functioning. So I got dressed and went into the emergency room that night. It was a wintertime, rather snowy night. And it was about 2 o'clock in the morning, and the child did indeed have a torsion of the testicle, and so we brought him to the operating room and explored that area and untwisted the testicle and reattached it to the surrounding tissue so that this would never happen again. So the patient did fine after that. His testicle was preserved. And my office manager told me after a couple months that no reimbursement was ever came in on that case, and so she inquired about it, and they told her that we did not have pre-authorization and no letters were written or anything else. So we sent a letter back saying that it was an emergency situation. There was absolutely no time for getting any pre-authorization or anything of that sort. So, but they declined the reimbursement, and this went on a couple months more, couple letters back and forth. Finally, I told my office manager, just write off that fee and let's just forget about it because it's not worth all that extra aggravation. Fortunately, about 2 weeks after we wrote off the service, a payment did come in. So I guess really they must have talked to some other managers about it and found out really that this was a reimbursable procedure. But since I've retired, I teach now out at NeoMed. That's our medical school, which is on Route 76, halfway between Akron and Youngstown. And it's been in operation now about 50 years. It's surprising. And we also have a pharmacy school there, and we also have a graduate school. And we're also, my brother and I have initiated this startup of a dental school there. There are only 2 dental schools in the state of Ohio right now, Case and Ohio State, and there's actually a big need for another dental school in the state. And we have passed all of our accreditations. The commissions have come and given us all the go-ahead signs, and so the buildings, we already have the buildings there, and they are being remodeled for the dental school. Each dental student will have his own operatory. It's quite expensive because he or she has to have their own chair and plumbing and everything else right there. And so that's being done right now. And we will be taking our first dental school class in this coming fall. And we'll start out with about 50 students, and it will go from there. We've already had about 1,800 applicants for 50 seats available. So we're looking forward to that coming along. But want to thank all of you today for this presentation, and I'm enjoying it and plan to be here the rest of today and tomorrow. So thank you.
Add just something, what Dr. Levy was saying about how he would not recommend his kids go into medicine. I don't mean to cause controversy, but I would absolutely tell my kids to go into medicine. I would not have 5 or 6 years ago. I mean, that's the type of, when you look and you see how big the pendulum has swung, I'm thinking like, these poor students are like, what the heck did I get myself into? It doesn't have to look that way, and that's why I think that this is the start of a change. At least that's my hope for you guys. So I don't want you to be discouraged that you chose this. It's a beautiful vocation, if that's what you would consider it. But at the same time, I am the first physician in my family, and it would have been nice to know what I was getting into if I had a heads up. If my mom was experienced, if I had the family input. So I just wanted to throw that out there just so that you guys didn't panic.
And if my kids want to go to medicine, that's what they want. Great.
So anybody else want to share their experiences with us?
Medical students too.
Medical students, did you have any experiences that you want to share with us? Problems that you've encountered in trying to. So, Doctor, yeah, go ahead.
Actually, can I comment on one other thing while we're thinking about that? Something that I think all three of us hit on, which is really interesting. We were in medical school and residency, you know, we're kind of graded on how much, I'm doing what we're told, right? In a sort of way, like, you know, if I have a medical student and I say jump and they don't say how high, I'm like, what's wrong with them? Now, granted, I know as a psychiatrist, I know as a human being, I know as a medical student myself, that's ridiculous, right? And we talk about too that we really, you know, medical school specifically looks for a certain type of personnel, but it's really interesting. You brought up that you were just at a residency and you just signed the contract and stuff. It feels really good when you become an attending physician, like really good after so long. When you're a medical student resident, just saying yes and saying how I need to worry about getting that 5, whatever. I don't know how I got to do it now. But like, you know, it's just so nice that first time someone dumps attention on you and like, ooh, you're gonna be a great doctor. We're gonna love you. You're gonna be a medical director one day. And again, I mean, it's not really negative about this. I love my job. But point is, we talked about. I think Jesse mentioned that. The other Jesse mentioned that too about like just you know when you're out, you know, being just really eager to sign the dotted line because that's what we're trained to do. And I'm not saying fight the system, rah. You know, I'm not saying like that. But you just got to be cognizant that when you know that attitude of saying yes and being a people pleaser is adaptive as a student and as a resident, but might cause little issues if you think about some of these more nuanced ethical issues.
I did take a couple notes that I wanted to share when I was thinking of how I wanted, what I wanted to share. Like if I could give any advice, it's to that point, not just be cognizant, but be confident. You got here. I mean, you could not have possibly fooled enough people to sit in this seat if you were not meant to be here. So congratulations. Feel good about that. So be confident in the value that you're going to be bringing to the profession. Remember your why. Don't compromise yourself. And then similar to the beginning of when we talked about patients, focus on the patients. Don't worry, everything else will work itself out. But it's very easy to be distracted by all the noise. But if you really put the patients first, you're going to win in the long run. For that out there, because I think you're right. Like we just think at least I didn't have the confidence early on to say that I was worth a contract negotiation. Like I was just thrilled to get a job.
I'm just glad that someone's complimenting you and keep taking an interest in you.
To add to that, you guys are all at a big academic institution. I was for med school, I was for residency. Many of your attendings, many of your residents, they've been in the academic world. For many of you, that's going to work. The academic world is going to be where you're going to thrive. It's going to be great. For those of us who aren't, aka the three panelists in front of you, find us, right? Come and talk to us. Ask your leader, your mentors, your whoever, hey, who do you know who's in private practice? Is there someone I can talk to? What else is there in medicine? Because not all of us are going to end up in academic medicine, and that's what you're exposed to as a student because that's where you learn. For the law students, you're probably not all going to become law professors. Ask and talk to those of us who are out in the rest of the world and the rest of practice to see what's out there, because you don't have to do what you see, but if you don't see it, you can't become it.
I think the business and marketing classes, if you could expose yourself, it doesn't have to be an official class through the school, but if you do some reading and research and are able to, everything I know about business is self-taught. I literally never took one business class, and I'm running my own business. It's wild to think about, but you have to be motivated to do that, and you have to go out of your way. I don't know what your curriculum is. Maybe you guys have it differently, but I agree with you. You have to kind of force it and put yourself in that position and network with people. Most of us, I mean, I don't mean to speak for you guys, but we would be happy to help in any way as you guys are moving along in your journey, and help answer questions. No need to reinvent the wheel. I'm happy to share how, the experience of how we did it. But yeah, I think that's a great point that you made, Dr. Cox, about networking and get to know the other ways of doing it, because unless you've ever seen it, you would have no idea.
Did we stall long enough? Do any students have any stories? Oh, good.
And while the microphone's coming, I want to share my little thing on my phone says, healthcare for profit is crime against humanity.
Yeah. Hi, everyone. My name is Julie Fox. I think eventually over the course of the forum, this will probably come out at some point because we're going to talk about private equity. But I actually used to work in private equity as an advisor. And during my time there, we focused on different industries, and healthcare was one of the industries I worked on some deals. And through that work, I started to learn a little bit about healthcare and about how little I knew about how things worked. And so that was one reason I started to look into it. But I also started to realize that people on my team, on the investment team for this large private equity advisory firm, didn't really have the like science background to make some of these critical decisions. We were making investment recommendations in the lines of hundreds of millions of dollars to get funding to support certain other funds that would invest in either tech companies or existing health practices. So I started to realize I don't have that background. Do my partners have a background? They don't have a background. So how who's making these decisions that are affecting healthcare practices? And ultimately, I just want to share that they're not thinking about patient outcomes. That's not the end goal. It's not that everyone's evil in private equity. That's not the case. I was working there. I don't think I'm evil, but and I have a lot of good friends that are still in that industry. It's just the alignment of interests are very different. And to one of your points, Dr. Levy, that you made earlier about being the squeaky wheels, one thing that I've started to learn when I quit that job, I ended up, started to look into what it meant to apply to medical school. So then I needed some clinical experience. I worked as a scribe at a community clinic. And there, I also was pretty surprised at how quiet some of the doctors were. This was out in San Diego, and they're, quiet in terms of asking, why are we still doing things this way? So I was asking the doctor I scribed for. And in my mind, I'm like, how is this still, how are these decisions being made? I'm trying to figure out who's the decision maker here. And there's this like deep seated like frustration amongst the doctors themselves. You like rant all day, and then, but I don't understand who's actually making these decisions. They're not patient facing. They're not physicians in those like leadership positions. So I really like what you said about being the squeaky wheel, because in my mind, I'm like, what's going on? What, like, why aren't people questioning this? And I think that I wanted to share that, because if we're not the ones questioning it, if we're not figuring out who is deciding what those interests are, no one's going to speak on behalf of the doctors. It's just not, it's not that they're evil, it's just that's the function of the system and how things are the way they are right now.
Other contributions, other tales?
Hi, I am not a doctor. And my background is I have an undergraduate business degree, I have an MBA, and I have a JD. So I'm simplifying this. I'm also coming out of business and human resources. As a doctor, your tool is your brain. Your skill set is analysis, is a detective analysis and coming to a conclusion. What's interesting to me, taking the long look, is that as physicians, you've in essence been divided and conquered, that you are so isolated. And I come to that conclusion when I go into my providers. I happen to be political. What's going on with abortion? What's going on with cutting the NIH? What's going on today was cutting out the medication for adolescents psychiatry. And
Probably microphone for 5 minutes and we get behind.
I'm sorry, no one editorialized.
check your newsfeed. I understand that individually you have a professional obligation. Individually, you have to support your family. But there's no group effort that I can see of addressing these huge issues. They're putting doctors in jail? Unheard of for doing what's right for the patient. I mean, what parallel world are we living in? So that was just my comment. Thank you.
Anybody else?
If I can address that for a sec. So I would say there are groups getting together, which is great. There's also, you go through medicine and you're taught the medicine of it and you know the medicine of it. And you've spent so long on this track that you forget that those skills can be used in other ways, right? So the three of us own our own practices. Not I didn't go to business school. Did you guys go to business school? So you can figure this stuff out and you can find ways without spending crazy amounts of time, right? Like somebody was saying, learn the medicine of it, learn the contracts of it. You're not going to do that as a med student. Like as a med student, you're just trying to survive. As a resident, you're just trying to survive. But at some point, after you become an attending and after you take a deep breath and you look around and you realize like, oh, I have a few hours a day to like actually do something other than just medicine. It's a great time to kind of get your head above water and try to find even just little places, coming to these conferences, talking to people, doing what have you, joining the Facebook groups of, I know Facebook is old, sorry, I'm old, of people who are actually doing things. I ended up in front of our state Senate giving a presentation similar to this on why corporate practice of medicine laws should be written. I had no idea I could do that, and they actually appreciated what I had to say. Who knew? So it doesn't take much, and you do have the power, and you do have the knowledge, and you do have the experience to figure it out.
So just to look ahead to tomorrow, one of our breakout sessions tomorrow will be asking everybody to sort of think about what can you do as medical students to try to fix, improve the situation. So just Dr. Cox is giving us a sort of preview of that. And also something that was mentioned by someone else in the last session before at the end tomorrow, we will talk about, is there anything that should be done differently in medical school to prepare medical students for what, you know, the kinds of things that we're talking about. And bearing in mind that time is limited in medical school, you have so much else that you have to do. but how can this be sort of introduced and made available? So that's all tomorrow. Dr. Tony?
Thank you, Max. I think one of the things that we're bringing up here is intrusion into your professional life. We got a little bit, I think, sidetracked by 3 people that were able to escape the intrusion into your life. But the fact is 80% of you are going to be employed. And whenever you're employed, the instinct of your employer is going to be make you a tool for their interest. Let's not kid each other. That's the problem. We have not told the truth. They're going to try to make you a tool for their economic interests. And I applaud Max Melman, the med school and the law school for sitting down and talking about this truthfully, frankly. And what are we going to do about it? How are you going to get your profession back is the question. Do you have the guts to take it back? And we're going to talk about it. And I'm not going to pull any punches when I speak tomorrow.
Dr. Friswold, did you want to say something?
Yeah, I actually have a question for the
microphone.
This has been a wonderful kickoff for this day and a half that we're going to have together. My question is, or my comment is about your story, Dr. Batante, about the testicular torsion. I mean, I retired 10 years ago. I learned in med school 50 plus years ago that testicular torsion is an emergency. And the notion that the company has to wait 2 to 4 months or however long it is to do something that was self-evident for anybody is really shocking. And the problem is there's no malpractice for insurance companies because they should have been paying you 3 times as much for the delay and the human hassle. So it's a question of who's in charge and how do we adjust who's in charge.
Anybody else? If not, in 2021, we had a conference here, the Law Medicine Center conference on electronic medical records. And Dr. Levy mentioned the problem of trying to check off whether his pediatric patient had a shot or not. And we were fortunate, we had experts describing the problems that physicians face in trying to deal with electronic records. And, excuse me, and we were fortunate that some of the speakers were able to actually show us slides from electronic records, which was actually illegal because, as you may or may not know this, but when a system, a record system is bought by a hospital for a system, one of the provisions is that nobody can download any of the parts of the record and show it outside of the of the practice itself. And they were able to show us, and I remember one where there was a screen which had to enter information about the patient, including the patient's diagnosis, and there were about 6 possible diagnoses at the bottom of the screen. And the problem was the patient didn't have any of those diagnoses. And the problem was that there was nothing on the screen that told the doctor that they could scroll down and find 6 additional possible diagnoses. And if you didn't have experience with it or training, you wouldn't know that. And we heard story after story after story about that. And finally, I was just perplexed. Why? How could this be happening? And I said, don't the records, vendors and creators, don't they beta test their systems? Don't they have doctors try to use them and find out these kinds of snafus? And they said, well, we do beta test it, but we ask for volunteers to do the beta testing. The people who volunteer to do the beta testing are the people who are very experienced in the computer systems and enjoy this kind of thing, not the actual people who will have to deal with the problems that are created. Other thoughts?
Well, can I just actually piggyback on that thought too? Because I mean, there's you talk about like actionable stuff, and to your point, about like most of us aren't gonna be able to escape or whatever. But there are things here. So when I was at the clinic, for example, I was the quality improvement officer for the Department of Psychiatry, and I learned a lot about how we interact with machines. For example, one of the things in adult psychiatry was they're supposed to check off a box about do they counsel about smoking cessation. The point being is that that would when you ask a physician to do something that is for a change of workflow to meet something, I'm gonna use the quote, bean counter, the reason why they had that was a good point, right? I mean, yes, you should be asking about smoking cessation and stuff like that. And I can imagine just in some boardroom somewhere, some of this is brilliant. Because not only that, but then you get credit from a money standpoint by saying counsel on smoking cessation. You can check off that Medicare, I think that's one of the quality outcome and things about discharge patients. That's great. And it looks great now. We cancel it, and so it looks wonderful. The problem is, like I said, it's not that it's not fun, but having these conversations about how can we change it? What are the physicians saying? Well, when you have this thing here and you say I counseled or not, it documents I didn't counsel. Well, then now, it gets to a point where I think when I think about bringing this up, it's like there are things even working within a system to advocate for to help our workflows and our priorities match up. Right? There could be different ways to phrase things, for example. I'm getting ahead of myself, but yeah, thank you guys. This is great.